Hormone receptor status in breast cancer, clinical significance and treatment implications. Hormone receptor status is a critical prognostic and predictive marker in breast cancer that determines treatment options and patient outcomes. Testing for estrogen and progesterone receptors guides therapeutic decisions and influences long-term survival rates. Understanding hormone receptor status in breast cancer. Hormone receptor status represents one of the most important biological characteristics that pathologists evaluate when analyzing breast cancer tissue samples. This determination involves identifying whether cancer cells express receptors for estrogen and progesterone, the same hormonal signaling pathways that normal breast tissue uses for growth and development. The presence or absence of these receptors fundamentally changes how cancer cells respond to their environment and which therapeutic approaches will prove most effective. This classification has transformed breast cancer management from a one-size-fits-all approach into personalized medicine strategies tailored to individual tumor biology. The biology of hormone-dependent breast cancer. Breast cancer cells that possess estrogen receptors depend on the hormone estradiol for their growth and survival, making them inherently different from hormone receptor-negative tumors. When estrogen binds to these receptors on cancer cells, it triggers a cascade of molecular signals that promote cell division, survival, and proliferation. This dependency creates both a vulnerability and an opportunity for therapeutic intervention. By blocking estrogen production or preventing its interaction with cancer cell receptors, clinicians can slow or halt tumor growth in ways that work specifically against hormone-responsive cancers while minimizing effects on hormone receptor-negative disease. How hormone receptor testing works. Laboratory pathologists examine breast cancer tissue samples using immunohistochemistry techniques to detect the presence of estrogen receptors and progesterone receptors on malignant cells. These tests measure the quantity and distribution of these receptors throughout the tumor tissue, providing quantitative or semi-quantitative assessments. Modern testing has become increasingly standardized, with laboratories following established protocols to ensure consistency and accuracy across different institutions. Results are typically reported as percentages indicating the proportion of cancer cells expressing each receptor type, and interpretation follows validated scoring systems that correlate with clinical outcomes and treatment response rates. Estrogen receptor-positive breast cancer. Tumors classified as estrogen receptor-positive account for approximately 75% of all invasive breast cancers and represent cancers whose growth is stimulated by circulating estrogen. These tumors typically grow more slowly than their receptor-negative counterparts, which generally translates to somewhat better overall prognosis when managed appropriately with hormone-blocking therapies. Patients with estrogen receptor-positive disease have access to a well-established arsenal of endocrine treatments that can suppress estrogen production or block its effects on cancer cells. The presence of estrogen receptor positivity opens doors to multiple sequential treatment options that can be deployed over many years to maintain disease control and quality of life. Key points. Aromatase inhibitors block the conversion of hormonal precursors to estrogen in postmenopausal women. Tamoxifen acts as an estrogen receptor antagonist, preventing estrogen from activating cancer cells. Fulvestrant functions as a selective estrogen receptor degrader, destroying the receptor protein itself. Ovarian suppression agents reduce estrogen production in premenopausal women by shutting down ovarian function. Progesterone receptor status and its clinical meaning. Progesterone receptors frequently coexist with estrogen receptors in breast cancer cells, and their presence carries prognostic significance independent of estrogen receptor status. Progesterone receptor positivity typically indicates a more differentiated tumor with somewhat slower growth kinetics compared to cancers lacking this receptor. The concurrent presence of both estrogen and progesterone receptors generally predicts superior response to endocrine therapy compared to tumors expressing only estrogen receptors. When progesterone receptors are absent despite estrogen receptor positivity, it may suggest slightly more aggressive tumor biology and sometimes warrants more intensive treatment approaches, though endocrine therapy remains the foundation of systemic treatment. triple-negative breast cancer and receptor-negative disease. Breast cancers lacking estrogen receptors, progesterone receptors, and HER2 amplification are designated as triple-negative tumors and represent approximately 10 to 15% of all breast cancers. These malignancies cannot be effectively treated with hormone-blocking therapies since the cancer cells have no hormone receptors to target. Instead, triple-negative breast cancer management relies on chemotherapy as the primary systemic treatment, often combined with immunotherapy approaches that harness the body's immune system to recognize and eliminate cancer cells. The absence of hormone receptor dependence typically correlates with more aggressive tumor biology, though some triple-negative cancers respond remarkably well to chemotherapy compared to hormone receptor-positive tumors. Prognostic and predictive value of receptor status. Hormone receptor status serves dual functions in breast cancer assessment. It provides prognostic information about likely outcomes and predicative information about which treatments will work best. Estrogen receptor-positive cancers generally demonstrate superior long-term prognosis compared to receptor-negative tumors of similar stage and grade, particularly when appropriate endocrine therapy is administered. The predictive value of receptor status is equally important, as patients with hormone receptor-positive disease can anticipate years or decades of treatment options targeting the estrogen signaling pathway, while those with triple-negative disease must immediately pursue chemotherapy and other strategies. This information guides not only initial treatment selection but also long-term surveillance and follow-up care planning. Key points: hormone receptor status helps determine which chemotherapy regimens will be most appropriate. Results influence decisions about radiation therapy timing and target areas. Receptor status affects eligibility for various targeted therapy clinical trials. Knowledge of receptor status informs surveillance strategies and follow-up imaging protocols. Extended endocrine therapy and long-term management. One distinctive feature of hormone receptor-positive breast cancer management is the opportunity for extended treatment durations that leverage the hormone dependency of cancer cells. After completing initial chemotherapy and radiation when needed, patients typically receive endocrine therapy for 5 to 10 years or longer, with some receiving continuous treatment indefinitely to suppress recurrence risk. This extended treatment approach is unique to hormone receptor-positive disease and reflects the underlying biology wherein cancer cells remain dependent on estrogen signaling even years after initial diagnosis. The ability to provide decades of effective systemic therapy with generally manageable side effects represents a major advantage for patients with hormone receptor-positive cancers compared to those without functional hormone receptors. Resistance mechanisms and treatment evolution. Despite initial sensitivity to endocrine therapies, some hormone receptor-positive breast cancers eventually develop resistance and progress despite ongoing hormone-blocking treatment. Cancer cells accomplish this through various mechanisms including mutations that alter estrogen receptor function, activation of alternative growth signaling pathways, and enhanced ability to convert hormonal precursors to active estrogen within the tumor microenvironment. Understanding these resistance mechanisms has led to the development of combination therapies that target estrogen receptors simultaneously with other signaling pathways, such as CDK4/6 inhibitors that prevent cancer cell cycle progression. These advances continue to expand treatment options for patients experiencing disease progression while on endocrine monotherapy, offering new opportunities to maintain disease control. Clinical application and patient counseling. Armed with hormone receptor status information, oncologists can provide specific, evidence-based treatment recommendations that address the unique biology of each patient's cancer. Patients with hormone receptor-positive disease learn about the advantages of extended endocrine therapy, potential side effects of long-term hormone suppression, and the rationale for particular treatment sequences. Those with triple-negative or receptor-negative disease understand the necessity for chemotherapy and the importance of early systemic treatment before cancer spreads. The receptor status also informs discussions about prognosis, likely treatment duration, and what patients might expect throughout their cancer journey. This transparent communication empowers patients to make informed decisions and maintain realistic expectations about treatment and outcomes. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.